Morning, I'm Dr. Michael Simonis. I will perform clinical examination of the knee. With me today is Aris, who is actually a friend of mine. Good morning, Aris.
Good morning,
I will
Mike.
perform some tests on your knee.
Okay.
If I provoke any pain or any discomfort, you should tell me and tell me to stop. Okay?
Okay.
First thing that I do when I perform examination of the knee is inspection, and the first thing that I want you to do is just come here in front of me and you put your feet together, and so this way I can assess for any valgus or varus deformity, and just step a bit aside to the side. Yeah, and now I will see if there's any evident pes planus deformity or things like that can contribute to pathology of the knee sometimes. Then I will ask the patient to just walk a bit, so you can walk over there. Okay, and come towards me now, please. Thanks. Okay, and this way I check if there is any evident imbalance or different ways of walking, or any pain that causes gait imbalances and things like that. Then I ask the patient to lie down, and you can lie. Yeah.
Okay.
Okay. So we will do examination of the knee, of the left knee. When there is pathology, I always start every test with the healthy knee, and then I will proceed to the unhealthy knee. So first things always is inspection. So we just look at the knees, we compare. We can see actually sometimes it's pretty evident when there is effusion or things like that, or other pathologies like full rupture of the patellar tendon that will cause the patella to move upwards, and we can easily see differences this way. Then I will perform palpation. I will palpate every major anatomical structure. I usually start from the quadricipital tendon here, and I will assess this tendon. Then I will check for the patellar tendon, and I will palpate two sideways of the patella, and then I will palpate for the ligaments, and so the lateral collateral ligament, who lies over here. It's a cord-like structure. Sometimes here I can really palpate it. Here sometimes it's very evident, and from the internal side I will palpate for the lateral medial collateral ligament, who actually is about over here, and he inserts really low, right about here. I can palpate for about here is also the tendon of the pes anserinus, so the semitendinosus, semimembranosus, and sartorius tendons. Then I will check for I will palpate and try to mobilize the patella. Sometimes there is a limited mobility of the patella, and then I will start, and at the same point I will check for any knee infusion. If there is presence of knee infusion, I will always do the same test both sides. There's no infusion present here. Then I will assess for range of motion, and I will do passive first, and so passive flexion and passive extension. I will see if there's any deformity present here. Then I will ask the patient to just raise his leg about over here. I do this for two reasons. First, to assess the strength and see if there is no evident tendon problems, ruptures or things like that. First, and second, I will help them and see if there is any pain which could show that in fact it's the straight leg test that can cause radicular pain over the knee. At the same point, when I do this, I assess a bit also the flexion of the hip, like that, and do fast hip tests that also can cause referred pain to the knee. I sometimes do just also this test for the hip, then when I'm done with the range of motion of the knee, of course I compare the two sides. I will do some specific tests, especially for the ACL. For the ACL, first, in fact, I just do. You just let me hold your foot, and I will first see if there is any posterior sag sign, which could mean that there is a problem with the PCL, the posterior cruciate ligament. Because if I have not found that there is a posterior sag sign, I can malinterpret. If I do the Lachman test, I can have a false positive Lachman test. So the Lachman test is the next test that I do, and I will just grab his quadriceps, and I will put my thumb on the tibial tuberosity, and I will move anteriorly his tibia, and if there is an ACL tear, we can feel the instability and the anterior displacement of the tibia. Of course, it's a test that should be bilateral to compare. That's one test for the ACL, and then and the second test is the anterior drawer test that I perform. So I put the two knees in flexion, and then I tell to the patient that I will actually sit on your feet. Okay, so I sit like that, and I perform the anterior drawer test. Here there is no instability, and I will check bilaterally. That's the two tests I do for the ACL, and then I will check for any problems of the medial collateral ligament or the lateral collateral ligament, which is just what I perform at 0 degrees of extension with valgus force. Here I test the medial collateral ligament, and then I do the same test essentially, but at 30 degrees of flexion, like that. And the same thing goes for the lateral collateral ligament. I do a varus force, I grab like that, and at 0 degrees of extension of the knee, I perform a varus stress, and at 30 degrees, I again perform a varus test. And here there's no instability. Of course, the same thing for these ligaments. We always have to compare with the right side, and of course, this is the basic examination of the knee. Depending on the pathologies that we suspect, we can perform more appropriate tests. I also, if there is, for instance, if I think of patellofemoral pain syndrome, which is very common, I will also do just a flexion of the knee and holding the patella and trying to look for any crepitus or things like that. Then sometimes if the pain is on the posterior side of the knee, I will ask the patient to turn around. Can we turn around, please? Thanks.
This way.
Yeah, great. And so now this is the knee with the pathology, and I will palpate the posterior aspect of the knee for any Baker's cyst. And sometimes, if I suspect any posterior tendinopathy or things like that, you can turn around, please. Depending on the pathology, if we suspect any neuropathy, we can perform the Tinner's test to see if there is any neural problem that can cause pain. Yeah, that's the basic examination I perform. For athletes, I also check for core stability and balance, just to assess if there's any problems with proprioception. I will do this. Can you step
Step up.
Step up, if it's possible, because sometimes the pain on the knee doesn't let the patient do these tests. I perform them with using the non-painful knee. So you just have to stand on one foot, like that. Great. We can see that Aris, his balance is not exceptional. And now I will ask you just to try to do a squat, like that. Okay, and I will see if there is any imbalance and things like that. Yeah, that's the basic examination I perform. Thank you.